This lecture is over care of patients with musculoskeletal trauma. It covers chapters 51. Alright, so now we're going to talk about fractures. Fractures is a break or disruption in the continuity of a bone. You can have different types of fractures. It can be a complete fracture, which means that the break is across the entire width of the bone in such a way that the bone is divided into two distinct sections, meaning that really the bone is broken straight down the middle into two pieces. An incomplete fracture is that it slightly fractures the bones, but it does not divide the bone into two portions because the break is only partially through the bone. You can also have open fractures. These are also known as compound fractures, where the skin surface over the broken bone is disrupted, causing the external wound. With open fractures, that is a direct portal of entry into the body, and remember what we talked about with osteomyelitis. That is a common complication of open fractures. And you can actually see the bone penetrating through the skin. With a closed fracture, it is simple. It does not extend through the skin and is not an actual visible wound. The only way that you can tell that there is a fracture is by x-ray. You cannot visualize the broken bone. The different types of fractures: pathologic is a spontaneous. It occurs after minimal trauma to a bone that has been weakened by a disease. Fatigue or stress fracture, it results from excessive strain and stress on the bone. Stress fractures are commonly seen in recreational and professional athletes, specifically running. You have closed non-displaced fracture, which the bone doesn't protrude through the skin and it isn't out of alignment. Anytime you hear non-displaced, that is a good thing. That means that the bones are still aligned. If you have a displaced fracture, that means that the bone is out of line and would need to be reduced and put back into place. A comminuted or fragmented fracture is a fracture with more than two fragments. The smaller fragments appear to be floating. And as I've already mentioned, displaced is a complete break where the ends of the bones are not aligned. And if it is displaced, as I said before, you would have to reduce it and put it back into place for it to heal. You can have an oblique fracture. Oblique fracture is a fracture in which the line of the fracture extends in an oblique direction. You can have a spiral fracture, which a spiral fracture is in which the line of the fracture extends in a spiral direction along the shaft of the bone. You can have an impacted fracture, which the bone fracture in which one of the fragments is driven into another fragment, or a green stick, and an incomplete fracture with one side splintered and the other side bent. I will show pictures on these in the next few slides. Here are those types of fractures that we just talked about. These are the most common. As you can see in the first picture, that is a closed non-displaced. It is non-displaced because the bone still lines up, as you can see. Then there's the open compound. Remember, open fractures, the bone actually protrudes through the skin. And this one is also displaced because the bones are not aligned. So this is an open displaced fracture. Then you have a comminuted or fragmented. As you can see, there's little fragments of bone floating in the space. This one is displaced. This is a closed displaced fracture. It's not protruding through the skin. the bones are not aligned, so this one would have to be reduced to align the bones back together. This one right here is an oblique, and it's oblique because of the way it's fractured in an oblique pattern. This one is a spiral fracture. As you can see, the fracture is in a spiral pattern. Impacted, there's a lot of pressure onto the bone below. And then there's little fragments in between. And then the green stick fracture is an incomplete fracture, meaning it's not all the way through and through. And one side of it is splintered and the other side is bent. Complications of fractures. The first one we're going to talk about is acute compartment syndrome. Acute compartment syndrome is increased pressure within one or more compartments that reduces circulation to the area. Compartments are areas in the body in which muscles, blood vessels, and nerves are contained within the fascia. Common sites for this to occur is in the lower legs and forearms. And is what happens is edema increases pressure on the nerve endings, causing pain. And then perfusion to that area is reduced, resulting in ischemia. So essentially is what all that means is that when you have an injury, such as a fracture, it could also be burns. There are other injuries that could lead to acute compartment syndrome. Right here, we're talking about fractures. But when you have a fracture or injury, it is the body's natural response to have inflammation. Inflammation includes swelling, and so when you have that inflammatory response and swelling, your leg is a compartment, and everything is supposed to stay within the fascia. But when that swelling exceeds the fascia limitations, then you have a problem, because essentially is what that's like is putting a rubber band on too tight. It starts cutting off circulation and causes problems and can lead to ischemia. And as I've always said, is that once something dies, it's really hard to bring it back. So we want to watch for signs and symptoms and treat that very early. So it's really important for us as nurses to recognize signs and symptoms of acute compartment syndrome. And one of the biggest ways that we monitor for that is we do the 6 P's of the neurovascular assessment. Remember, the 6 P's is going to be pain, and with compartment syndrome, that may be one of the first things that you notice is they just keep on saying that they have severe pain, that the pain is continuously getting more intense. They may have paresthesia, which feels like the tingling, pins, needles. We need to check their pulse, make sure that they have good pulses in the injured leg or extremity. We need to look for pallor, compare sides. Pallor is paleness. Pressure, do they have good pressure sensation? And do they have any paralysis? Paralysis is a very late sign, so we want to catch it before they experience any paralysis. So, I mean, with acute compartment syndrome, you may find that their extremity is very pale, that pulses are weak, and without treatment, it can lead to cyanosis, numbness, tingling, and even necrosis. And we want to prevent that from happening. If all those do happen and we don't catch it, it can lead to permanent contractures, persistent motor weakness, can even cause infection, and need amputation. So as I mentioned before, the swelling exceeds the fascia, and so how we treat this surgically, this is an orthopedic emergency, and is what they do is a fasciotomy, and that's where they open the fascia and allow for the swelling to continue. The wound is left open and it's packed until it's reclosed in 4 to 5 days. Now sometimes they don't actually reclose it like with sutures. That's usually contraindicated because they don't want to suture an infection. So is what they may use is a wound vac, or they may even do a skin graft for healing. The next topic is crush syndrome. Crush syndrome is major shock and renal failure after a crushing injury to a bone. Hypovolemic shock, that's usually due to bones are very jagged, and when they break, they can cut arteries and other vessels and cause hemorrhaging. So with hemorrhaging, you can have hypovolemic shock, meaning low volume, body goes into shock. You can have fat embolisms, and we're going to talk about fat embolisms. So fat embolisms are often misdiagnosed as a pulmonary embolism or blood clot, like an actual venous thrombosis. But the difference is this is an emboli, but the emboli is from fat. So the fat globules are released from the yellow bone marrow into the bloodstream, and this happens due to the fracture. Early manifestations of this would be low arterial oxygen level. They may have shortness of breath. The hypoxic state may cause a headache. They may become agitated. They could be confused or even lethargic and decreased level of consciousness. They may have seizures, vision changes. You may find petechiae over the neck, upper arms, or chest. Diagnostics that we can use to diagnose a fat embolism is going to be a decreased PaO2, which is an arterial blood stick. They may have an increased sed rate, decreased serum calcium levels, decreased red blood cell and platelet counts, increased serum level of lipids. The chest x-ray may show bilateral infiltrates, but otherwise normal. The CT may reveal patchy distributions of opacities. The MRI of the brain may show evidence of neurologic death. It can cause respiratory or death. I do want you to know that like a fat embolism has a very high mortality rate. It's really hard to treat. With venous thromboembolisms, so this is the venous, like this is a blood clot, and often they are deep vein thrombosis, but remember with your deep vein thrombosis, those can go up. They like to travel up, and as they travel up, that turns into a pulmonary embolism or a myocardial infarction or cerebral vascular accident. Another complication would be infection. Osteomyelitis can happen, specifically more common in your open fractures, because the open fracture is a direct portal of entry that can cause osteomyelitis, and we discussed that in our part 1 lecture. They can have pneumonia. Pneumonia happens because they aren't as mobile as they normally are with the fracture. They may require surgical debridement. Some chronic complications such as ischemic necrosis and delayed union can happen. Ischemic necrosis is blood supply to the bone is disrupted, causing decreased perfusion and death of bone. Delayed union is a fracture that is not healed within 6 months of injury. Assessment of fractures. First, they just had a fracture of a bone, so that indicates possible trauma to other parts of the body. If they had force great enough to actually break a bone, then we need to assess other parts of their body for trauma. So we need to look at their head, look at their chest, abdomen, and just really do kind of a full head to toe look over for any other signs of trauma. We also need to assess their pain. If it is a long bone fracture, such as like the femur, then it is mandatory for us to give pain medication within an hour of them being in the emergency department. So we need to control their pain with analgesics. Usually it is narcotic analgesics, and for big fractures we will do like Dilaudid or Demerol or morphine. We also need that initial pain scale, because that initial pain scale tells us, are they continuing to grow in severity of pain, which could be an indicator of compartment syndrome. So we do need to have that initial pain scale documented. We also need to look at the bone alignment, and is what we're looking for there, is it internally or externally rotated? Is it dislocated? Is it an open fracture? Is the bone displaced? Those are all things that we're looking for when we're looking for bone alignment. With hip fractures, a lot of times you will have that internal external rotation. That's one of the big indicators that you have, and the leg may even be a little shorter on that side that you suspect the fracture on. The neurovascular assessment, we've kind of already hit on this, and if you look at chart 51-3 on page 1037, it discusses these with musculoskeletal injury, and is what we're looking for is the 6 P's. Do they have pain, pressure, paralysis, paresthesia, pallor, and pulselessness? So always remember that you're checking these things distal to the injury. Diagnostics, x-rays can show bone fractures, however they may need multiple views. A CT for fractures of complex structures such as hip, pelvis, and spine may be indicated. Non-surgical management of fractures. We've kind of already hit on pain management, as I mentioned that they will require IV narcotic pain medication. Usually it is an IV opioid. We're going to immobilize the fracture, and we do that in several different ways, but we ultimately splint where the fracture is. There are commercial splints. The most common one is a thermoplastic splint, which fits the patient's body, then wrapped with an ACE bandage. And is what they do is they get the splint wet, and then it molds to the extremity. But unlike a cast, it doesn't completely go around the entire arm. It only, and I just said arm, I meant extremity. Whatever the affected extremity is, it'll only go on part of the extremity that is injured. And the reason that splints are preferred initially is to prevent compartment syndrome from happening, because when you have a cast, the cast does go around the entire extremity, and that limits the space that you're allowed to swell, and that's what happens when you have compartment syndrome. So we want to put on a splint first, and that does allow room for swelling, and then we'll move to a cast. And there are different types of cast. You can have a fiberglass cast, and yes, they do come in a waterproof material in some places. Some places can offer a waterproof material. It is available in areas. There are plaster cast. I will say that the fiberglass is more common now than the plaster. And the reason being is the fiberglass, they dry a lot quicker. The plaster casts are wet for 24 hours. Complications of wearing a cast, the biggest one is going to be skin breakdown and circulation impairment. We do need to watch for that compartment syndrome, so we're still monitoring distally. So for instance, if the arm is in the cast or the wrist is in the cast, then we're going to look at the fingers, and we're going to assess the fingers for the 6 P's. Traction is another type of immobilization. Traction actually uses force, pulling force on part of the body to provide reduction and alignment and rest. You can have running traction, which is the pulling force in one direction and the patient's body acts as a counteraction. You can have balance suspension, which provides the counter traction. You can have skin traction, which uses a Velcro boot, also known as Bucks traction, a belt or halter, which is usually secured around the affected leg, and then a weight is used as a pulling force, which is limited to 5 to 10 pounds, and that's skin traction. And then you have skeletal traction, which is where they actually surgically place screws that are directly into the bone. An example, the biggest skeletal traction that I can think of would be the halo traction, and that halo traction is around the head, and it allows for longer traction and heavier weight use, which could be 15 to 30 pounds, whereas the Bucks traction is just 5 to 10. If they do have the skeletal traction, then you actually have to provide pen care. And when you provide pen care, is what you're doing is preventing infection. With all traction, weights should be free hanging and not lifted manually or allowed to rest on the floor. We need to inspect the skin at least every 8 hours. And always check your orders. Make sure that your weights are the prescribed amount. Make sure whatever's hanging is what is supposed to be hanging. With bone reduction, that is realignment of the bone ends for proper healing. So if you ever hear of a reduced bone, that's the same thing as a bone reduction. It can be closed or open. Remember how I said that open fractures are still displaced, and anytime you have a displaced fracture, it has to be reduced. And so that's what they do with the bone reduction. They will reduce it back into place so that the bone can properly heal in good alignment. If it is a closed reduction, they can do that using moderate sedation. We do that in the ER. We'll give the patient moderate sedation, and it does take 2 providers to usually reduce the fracture. And the reason why it takes 2 doctors is one doctor is supposed to be performing the actual procedure, and the other doctor is supposed to be maintaining the patient's airway and make sure that they're adequately perfusing and breathing correctly, because we are giving moderate sedation. It's really important that we assess their neurovascular status. We've kind of already hit on that, but it is every hour for the first 24 hours and then every 1 to 4 hours thereafter, depending on the type of injury. We want to elevate the extremity. That helps reduce swelling. Apply ice for the first 24 to 48 hours to reduce edema. After the first 48 hours, ice is really just for comfort. It doesn't actually help reduce any swelling after that 48-hour window. Drug therapy, we've kind of already hit on this too. Opioids and non-opioid analgesics. Anti-inflammatory drugs, this kind of depends on who you talk to. There is some studies that show that NSAIDs can actually reduce the swelling, which helps with pain. However, NSAIDs can delay bone healing, like the actual bone itself. So it just kind of depends on who you talk to on that one. They may prescribe muscle relaxants to help with pain. They may do electrical bone stimulation, which delivers a small continuous electrical impulse directed towards the non-healed bone. They may do low intensity pulsed ultrasound, which is 20-minute treatment every day to promote healing. Physical therapy to regain strength. They may require mobility aids, which we're going to talk about this with the PTA collaboration, using crutches to prevent axillary damage. There should be 2 to 3 finger breaths between the axilla and the top of the crutch. When the crutch tip is at least 6 inches diagonally in front of the foot. Elbow should be fixed no more than 30 degrees when the palm is on the handle. Educate them on how to use a walker and cane properly. With the cane, you want to place it on the unaffected side. No more than 30-degree flexion of the elbow. Top of the cane should be parallel to the greater trochanter. And we'll actually demonstrate this in our collaboration. Surgical management of fractures. Open reduction internal fixation, or ORIF, is where they use metal pins, screws, rods, plates, or prostheses to immobilize the fracture. And they do that internally. So then when they close the patient up, you don't see anything externally. They may or may not go back in and remove the pins. It just depends on what type of procedure that they had. But when you get that patient out of surgery, you don't see anything externally. With the external fixation, you do. It is an open wound, and there are pins or wires that are inserted through the skin to the affected bone and then connected to a rigid external frame. So external fixation, that would be kind of like your halo traction, you know, like you have the screw, they went in there and they placed the screws. So you do have to provide pin care. It is normal within the first 48 to 72 hours for you to see a clear fluid drainage. You do have to monitor pins every 8 hours and provide care per facility policy. Different facilities have different policies on that. Bone grafting would be the next surgical management of fractures, and bone grafting is what they do is chips of bones are taken off from the iliac crest or other site and are packed or wired between the bone ends to facilitate a union to bring them together. This is an ankle open reduction internal fixation, ORIF. So this is where they actually opened it up. They opened it up and placed the pins, as you can see, or screws. Actually, these are screws, plates, lots of screws. There's different size screws. So nursing care for fractures is going to be safety precautions, just making sure that they don't fall again while they have a weak bone as is. Teach them how to take care of their cast, how to shower with the cast. If it's not a water resistant cast, they have to wrap it up while showering. If it is a waterproof, they need to know how to dry the inside. A lot of times they'll educate them to use a hair dryer inside of it. Wound care, if there is any wound care. Their diet should be high in protein, calcium, and iron to promote bone healing, wound healing. Okay, so upper extremity fractures, the humerus, the proximal humerus is one of the most common in older adults. The distal radius is the most common upper extremity fracture. You have two different types of distal radius. The Colles fracture, which is when a person attempts to break a fall by landing on the heel of the hand when the wrist is extended. The Smith fracture is when they attempt to break a fall and then they are flexed wrist. The nursing interventions, make sure you remove jewelry on the affected hand and wrist before the swelling worsens. Perform neurovascular assessments. Make sure to immobilize the affected upper extremity. Elevate the upper extremity. Apply ice. Ice is good for the first 48 hours. And manage their pain. Alright, lower extremity fractures, including hip fracture, femur fractures, tibia and fibula fractures, ankle fractures, and toe fractures. So hip fractures is the most common lower extremity fracture of elderly. It can be actually fatal in elderly patients, as they have a hard time recovering from a hip fracture. So it has a high mortality rate. Over half of older adults experiencing a hip fracture are unable to live independently, or many die within the first year after hip fracture, which is sad to think about. The procedure of it is a lot of times they will do an open reduction internal fixation. They'll put a rod, pin, prosthesis, compression screw, and then post-operatively they'll come out and we'll put Bucks traction on them. The Bucks traction is the Velcro that has the end where you hang the weight. The weight's 5 to 10 pounds, and then we manage their pain. And usually how we manage their pain is with an PCA morphine pump, or we're giving them IV morphine. Some places will do a femoral neck block, nerve block. They'll do a nerve block to help with the nerve pain from the surgery. These patients will be on bed rest. Early mobility and early ambulation is important. It decreases the risk of infection, decreases the risk for blood clots. Just has better outcomes if they have early ambulation. Femur fractures are usually a result from trauma. That is a very large bone. It's very hard to break that. And a lot of times if you do have fatty emboli, it's usually from your femur fractures. They're not usually casted because the muscles of the thigh become spastic, which causes displacement of the bone ends. The treatment is usually the open reduction with internal fixation with nails, rods, or a compression screw. External fixation may be used instead if there is extensive bone fragmentation or severe tissue trauma. Healing time is usually 6 months or longer. Like, that's a huge bone, and it takes a long time for it to heal. Your tibia and fibula fractures, treatment is just closed reduction with casting, internal fixation or external fixation. Ankle fractures is described by their anatomical placement of injury. The treatment is usually an open reduction internal fixation with screws and nails and plates. Toe fractures are closed reduction or an open reduction internal fixation. This is a picture of Bucks traction. As you can see, it's like the Velcro, like almost kind of like a boot, except for the foot's open, and then it has the traction, and then the weight's hanging on that string. So fractures of the chest and pelvis. Chest, the major concern with chest fractures or rib fractures is the potential of it to obstruct the airway, breathing, and circulation. For instance, I recently had a patient in the ER that came in. She had Parkinson's disease, and she had tremors, and she was unsteady, unbalanced, and fell backwards on steps, and she had a transverse fracture from T2 to T7 all the way down, and then had multiple rib fractures in addition to that. She was stable, but we admitted her to the critical care unit because of the possibility of risk for her airway, breathing to be altered if those bones moved or if something punctured. So anytime we have chest, ribs, we worry about airway and breathing and circulation. There's nothing really that we can do for rib fractures. They have to heal on their own. It's very painful. We can offer them a abdominal binder and kind of sometimes you can bring that up higher and put it on the chest, and it helps support. Manage their pain. These patients are at high risk for pneumonia because they don't deep breathe. They like to shallow breathe. With pelvis fractures, we have to assess for internal abdominal trauma, meaning internal bleeding. There are two types of pelvis fractures. You have non-weight bearing and weight bearing. And before I go into those, I'm going to go back for a minute. So pelvis fractures, usually pelvis fractures happen from trauma. It is the second most cause of death from trauma. And is what happens is like your iliac crest, it becomes like a razor blade. And you have your femoral artery really close. And you also have your your renals close to there, your kidneys, your spleen, your liver. It's all kind of confined in that area. And so if you have a pelvis fracture, I mean, it's kind of like a sharp object that could potentially nick any of those organs. So they are a huge risk for bleeding and internal abdominal trauma bleeding. So we need to assess for the bleeding, internal bleeding, by looking at their urine, looking at their stool, and watch their belly. And you need to watch their belly for swelling and if it becomes really rigid, because if they come in and their belly's flat and then all of a sudden their belly's large, there's something going on. So going back to the two types, non-weight bearing means that it's the pubic rami or the iliac crest. The treatment is bed rest on a firm mattress or bedboard, stool softeners, and healing time is usually 2 months. With weight bearing, it's multiple fractures of the pelvic ring. The treatment is open reduction, internal fixation, or external fixation or both, and it may be as long as 12 weeks. Anytime you have a pelvis fracture, you need to stabilize the pelvis. And some people have pelvis binders, and sometimes we use sheets. In the ER, if we don't have a pelvic binder, we will tie sheets and try to tie it as tight as we can to keep the pelvis together and stabilized. Compression fractures of the spine, most associated with osteoporosis or metastatic bone cancer or multiple myeloma. The manifestations is going to be severe pain. They may have kyphosis or occasional neurologic compromise. The management is going to be bed rest, analgesics, nerve blocks, physical therapy. Surgery will be vertebroplasty or kyphoplasty, which are both minimally invasive, and that's where they inject the bone cement through the skin directly into the fracture site, and it's like almost kind of like the bone fuses together. Amputations is removal of the body part. There's different types. You have elective or traumatic. Elective is related to complications such as peripheral vascular disease, arteriosclerosis, or diabetes. Traumatic would be usually from like a war or accidents, trauma. The primary cause of traumatic is the primary cause of upper extremity amputations. The elective can be either or. There's different levels of amputation. You have lower extremity amputations, which are performed quite a bit more often than upper extremity amputations. Lower includes toe amputations, which causes very minor disability. The great toe is significant because the great toe helps stabilize balance. It helps patients walk. Your great toe actually helps you push off to walk. Mid-foot amputations are common for peripheral vascular disease. Below the knee amputations, effort is made to preserve the knee joint. Above the knee amputations means that they had to come above the knee. Hip disarticulation is removal of the hip joint. And usually that's due to like cancer. Let's see. The higher the amputation, the more energy needed for mobility. The upper extremity amputation is more incapacitating than one of the leg. We use our hands for everything. So if we're able to save any part of it, we need to try to save as much as we can and maintain as much function as we possibly can. There is a lot out there with prosthetics. It's advancing every day. So that is an option, and it's good to educate patients on possible prosthetic devices and try to get them in touch with people that can make that happen. Complications include hemorrhaging, infection, phantom limb pain. Phantom limb pain is real. They feel the sensation of the nerve endings. Just because they cut the nerve endings does not mean that those nerve impulses know that they were cut. So their nerve impulses still try to signal to the brain that their leg is still there. So patients may say, my foot itches, but they've had their foot amputated. They still have those nerve endings, and sometimes will even have pain or strange sensations of the limb that's not even there. But that's because of the nerve impulses. Some people have reported pain, phantom pain, as intense, burning, cramping, or crushing. Neuroma is a sensitive tumor consisting of damaged nerve cells. It's treated surgically or non-surgically. If it's surgically removed, it often regrows and is more painful than it was before the surgery. Non-surgical includes nerve blocks, steroid injections, or cognitive therapies such as hypnosis. Flexion contractures of the hip or knee include proper positioning, active range of motion, exercises to help prevent this complication. So this is a below knee amputation. See, here's the knee. There's below knee the amputation. So if it was up here, it would be above. The knee joint would not be there. Assessment of amputation. It's important to monitor their neurovascular assessment, including circulation in both legs. You always compare one side to the other. Looking at their skin color, temperature, sensation, pulses in both, edema, looking for edema, ulcerations, necrosis, even hair distribution. The psychosocial assessment is like their grieving process. I mean, they just lost a limb. That is a part of them. They're going to grieve. So make sure that they understand that it's okay for them to grieve. They just had a loss. We need to talk to them about how it's going to affect their body image and their self-esteem. are they going to lose their job because they're not able to perform their task? What's their life going to be like after the amputation? We need to talk about those things before, and then reinforce it after and come up with a plan. Assess coping strategies, testing. They'll do blood flow studies using a Doppler or ultrasound. They may do an ankle brachial index, which divides the ankle systolic pressure by the brachial systolic pressure, which a normal is 0.9 or higher. Management of an amputation, traumatic amputation, you need to assess airway and breathing, airway, breathing, circulation. Apply direct pressure. Make sure you elevate the extremity. Do not remove the dressing. So like if it's still bleeding, you just keep adding more and more to it. More gauze, more pressure. Wrap the severed part in dry, sterile gauze or a clean cloth, and place it in a watertight, sealed plastic bag if possible. You always want to put it in ice water, never directly in ice. So it's supposed to be 1 part ice, 3 parts water. You want it in cold water, not just ice, because ice does not, like you would have colder parts on different parts of the severed limb, and which can cause damage. You need to put it in cold water, cold ice water. Avoid contact between the finger and the water, I guess, or not just finger, body part. You don't want to directly put it into the water. You need to have like a watertight bag. Put the body part into the watertight bag, and then seal it, and then put it in the ice water. Care of an amputation depends on the type and location of the amputation. You always need to collaborate with rehab services after an amputation, because they're going to be the ones that are going to have to try to get them back to doing their normal ADLs, or try to customize it for them to go back home and live independently. We need to monitor for sufficient tissue perfusion, manage their pain. We usually use opioids for pain, but pain is, if it's a phantom pain, the opioids don't usually help. If it's phantom pain, then remember that phantom pain is a nerve pain, and so we need to treat it with a nerve medication such as gabapentin or Lyrica. And there's some other medicines that they use too, such as calcitonin, beta blockers, baclofen, which is an antispasmodic, or antidepressants. The patient will also be on physical therapy. They may be doing massages, heat, TENS unit, or ultrasound therapy. If they have drains, monitor their drains. Watch for output. The skin flap should be pink, not discolored, depending on the skin tone. Should be warm, not hot. They'll be doing antibiotic prophylaxis. Depends on the type of amputation and how long the amputation is going to take, but usually they do antibiotic prophylaxis before surgery. After surgery, they will have a pressure dressing. As I mentioned, monitor the drains. Usually the drains are in for 36 to 48 hours after surgery. The physical therapy, they'll be working with physical therapy. Stump shaping stump shaping, they put air splints or elastic bandages, or they'll put rigid removable dressings to try to shape the stump into make it round, and then prosthetic fitting. And they do have to shape the stump in a certain way for them to be able to fit for prosthetics. Complex regional pain syndrome, also known as reflex sympathetic dystrophy. It's a very poorly understood dysfunction of the central and peripheral nervous system that leads to severe and chronic pain. It could be genetic. Most often results from fractures of other traumatic musculoskeletal injury from a previous injury. A lot of times it manifests in the hands and feet. These manifestations include changes in color, temperature, and sensitivity of skin, excessive sweating, edema, paresis, which is paralysis, partial paralysis, muscle spasms, loss of function, intense intractable burning pain. The priority of this syndrome is pain relief. The drug therapy includes topical analgesics, antipyretics, antidepressants, corticosteroids, biphosphonates, and analgesics. The non-pharmacologic modalities is going to be external or internal implanted devices or acupuncture. The sympathetic ectomy is cutting of the sympathetic nerve branches to treat this syndrome. With knee injuries, you have to ensure that there's no spinal cord injury. Make sure that there's rest. Immobilize above and below the joint. Apply ice intermittently for the first 24 to 48 hours. Ice is good for the first 24 to 48 hours, and then after that, it's best to use heat because ice will only help with swelling and inflammation for that first 24 to 48 hours. We need to elevate, use compression for the first 48 hours, assess neurovascular status. The different types of knee injuries is the patellofemoral pain syndrome, which is runner's knee. It's pain behind or around the patella. The treatment is going to be rest, physical therapy, bracing or splinting, and mild analgesics. If pain lasts more than 12 months, they may need to go underneath a scope and to investigate further. A torn meniscus is pain, swelling, and tenderness in the knee, clicking or snapping sound, which can often be heard when the knee is moved. The treatment of this is going to be manipulation, splinting, or casting, or they'll cut the meniscus. The ACL tear is patient feels a snap and the knee gives away because of the ACL laxity. Within hours, the knee is swollen, stiff, and painful. It is confirmed with an MRI. The treatment is exercises, bracing, activity limits, surgical repair, or reconstruction. The healing time for an ACL tear is 9 months or longer. It is a long recovery. This is a knee arthroscopy, just showing what it would look like through the scope. So there's the tibia, the meniscus, the femur, and the ACL right there. All right, carpal tunnel syndrome is the median nerve in the wrist becomes compressed, causing pain and numbness. The causes is excessive hand exercise, edema, hemorrhage, rheumatoid arthritis, diabetes, or repetitive hand activities. It is the most common repetitive stress injury. The manifestations is pain that is worse at night, numbness, especially in the morning, paresthesia, which is painful tingling. Some people describe it as a weak pinch, clumsiness, difficulty with fine motor movements, The diagnosis is Phelan's wrist test. The wrist is placed in flexion and it produces paresthesia in most patients within 60 seconds. The tinal sign is paresthesia caused by tapping lightly over the area in which the median nerve in the wrist lays, or nerve conduction studies. Management is non-surgical is going to be NSAIDs, corticosteroid injections, splint or hand brace during the day, night, or even both, laser or ultrasound therapy. Surgical intervention is going to be cutting or removing the cause of nerve compression. They can do it endoscopically or open, and then we would have postoperative care. And the incision right here is, they go in right here on the wrist, and then they released the median nerve. You see how it's so confined? They release it so it's not, and then they have mobility back in their hands without pain. Tendinopathy and joint dislocation. You have the Achilles tendon rupture, which you would treat with RICE, which is rest, ice, compression, and elevation. It can be surgically repaired or transplanted. It's very, very painful. With joint dislocation, the manifestations is pain, decreased mobility, alteration and contour of the joint, deviation in the length of the extremity, and rotation of the extremity. Usually with joint dislocation, the most common is going to be shoulder. Next would be like hip, knees, or fingers. The most I've seen in the ER is usually shoulders, and is what we have to do is we have to reduce it. It's a closed reduction. We can do it in the ER. We use moderate sedation and reduce the extremity back into place. And if there's no fracture, then their shoulder goes right back into socket, and then they get to go home and they feel fine. It's usually instant relief once that's relocated or reduced back into place. If they keep having reoccurrent dislocations, they may be fixed with wires or other devices. And usually if they've had one dislocation, they're more susceptible to having it more frequently happen in that same extremity, same place. This is an elbow dislocation. When I was 2, my mom actually like flipped me over, like her shoulders with holding my hands, and flipped me over, and it popped my elbow out of place and it had to be reduced. So it's not fun. The elbow's really like a hard reduction. It's hard for the physicians to get that one reduced back into place. Strains. Strain is from excessive stretching of a muscle or tendon. The management is going to be just cold and hot packs, exercise, stretching, limit activity, anti-inflammatory drugs, NSAIDs, muscle relaxants, or surgical repair. There is different degrees of strain. You can have a first degree, which is mild inflammation but little bleeding. Swelling, bruising, and tenderness are present. With second degree, it does involve tearing of the muscle or tendon fibers without complete disruption. The muscle function may be impaired. With third degree, it means a rupture of muscle or tendon with separation of muscle from muscle, tendon from muscle, or tendon from bone. With third degree, they have severe pain and disability results. Sprain can be an excessive stretching of a ligament. It causes pain and swelling. It's classified based upon severity, and it also has different degrees. It has first, second, and third, just like strain does. Sprain has first degree is mild. You treat with rest, ice, compression, elevation. With second degree, it requires immobilization and partial weight bearing during healing. Third degree is immobilization for 4 to 6 weeks. May require surgery for chronic joint instability. Rotator cuff injuries. So your rotator cuff is located in your shoulder area, and so these injuries cause shoulder pain. The shoulder pain is usually more intense at night and with overhead activities. You can have different types of rotator cuff injuries. You can have a partial thickness tear, which is usually more painful than the full thickness tear, but the full thickness tear can result in more weakness and loss of function. With the full thickness tear, they cannot easily abduct the arm at the shoulder, meaning bring out the arm from the shoulder. The arm will usually drop as the arm is abducted. They diagnose a rotator cuff injury. First, they'll get an x-ray. They may do an ultrasound or CT, but ultimately the MRI will determine if it is a partial or full thickness tear. They manage it with NSAIDs. They can try to do steroid injections at the site. They usually don't do more than 4 of those a year. And they'll try to do physical therapy to heal it, especially if it's a partial thickness. They'll try all those things first, put them on activity limitations, and see if it'll heal on its own. If it does not heal on its own, or if it's a full thickness tear, then it will require surgical repair. And surgical repair is usually done microscopically. They'll make very small, minimal invasive incisions. It is usually done outpatiently. They'll do a nerve block, and then they'll do heavy sedation. And that heavy sedation usually requires like an LMA, which is a type of tube that we'll discuss later on in critical care, but it's a type of tube, but it's not quite as invasive as intubating with an ET tube. It is a form of intubation, and it secures the airway, but they can't be used for long procedures. So this is a very short procedure, usually takes anywhere from 1 to 3 hours. And then after it's surgically repaired, they will be immobilized for 6 weeks, and they do have a sling that has an abduction pillow. The abduction pillow is there to keep that joint abducted from the shoulder joint. And they have to wear that for 2 weeks, and then they would be in a sling for 4 weeks. So they are immobilized for several weeks, and depending on what type of tear, if it was partial or full thickness, will depend on when they start their physical therapy. I believe that partial thickness, they will start it a little bit earlier, and the full thickness, they would have to wait the full 6 weeks before they start physical therapy. Here's a picture of a rotator cuff repair. As you can see right here is the rotator cuff. Here's the humerus, and this is where they're going in to try to repair it. Alright guys, so this concludes our musculoskeletal lecture, and if we did not cover it in these PowerPoints, this is what is going to be on the exam, okay? I know this was a lot of information. If there is any muddy points, please send me an email and let me clarify, and I'll even send it out to the class. I mean, if you're having a question, there's a good chance that somebody else may have the exact same question. So send it to me. Let me address it before the exam.